Welcome to Healthcare Data Matters. My name is Jamie Waugh, and I will be your host for this session. Today, we will be talking with Dr. Lindsey Knake, who will present a series of case reviews to demonstrate the power that native resolution retrospective data can have in supporting clinical care and the development of patient-centered predictive analytics. Next slide. Before we begin, we have some disclosures around funding and the operation of Healthcare Data Matters that can be viewed on this slide. Next slide. Joining us today is Dr. Lindsey Knake, Associate Chief Medical Information Officer, Inpatient Pediatrics from the University of Iowa. Next slide. Great to have you with us today, Dr. Knake. Our session format is as follows. I'll ask you questions that give you the chance to present your work to our audience. Audience members can type any questions they may have in the Q&A tab as shown on this slide. At the end of the session, we'll address as many questions as we have time for. Okay, let's dive right in. Dr. Knake, can you tell us about the supraventricular tachycardia, or SVT, case and how you leveraged the time series waveform data to support this patient?
Yeah, thanks, Jamie. I'm really excited to be here today. And these are three real cases that we saw in our NICU at the University of Iowa. So I'll go ahead and get started with case one. So this was a baby TS, as I'll call him, who was stable in kind of our discharge unit, our lower acuity unit, just working on feeding and growing. He was previously born at 22 weeks gestational age in our NICU, and he was older now, corrected to 36 weeks, just working on trying to get home. He was still being followed closely for retinopathy of prematurity. So that's one of the reasons he was inpatient and being monitored weekly for that. He was still on some respiratory support on RAM CPAP is what we were using. And we set kind of a floor of oxygen of 60% to treat that retinopathy of prematurity. And he was on a number of different chronic lung meds because of his diagnosis of BPD, bronchopulmonary dysplasia, or chronic lung disease. So he was on full feeds, eating, growing, not having any real complications. And then, of course, one night in the middle of the night, his heart rate spiked and he went into SVT, or supraventricular tachycardia. Next slide, Karen. And so this wasn't my patient, but because I was the attending in the higher acuity unit, he got transferred to me the next day. And so as I was getting ready to learn more about him, I actually used sickbay to look back and see what happened overnight before I was taking care of him. So you can see here on the different heart rate curves that we just showed, you could see his baseline heart rate was, more around like the 140s, 160s, and you can see a pretty marked change when he flipped into SVT and his heart rate was closer to 300, which is definitely abnormal and suggesting pathology going on for him. The next slide. And so I had shown the hourly view just to see the trend of what happened overnight, but this is actually where I zoomed into a 15-second view where you could actually see the moment where his EKG strip on that Phillips 2 strip went from being normal to jumping into an SVT morphology where we lost the P waves and he was very abnormal at that time. And you can see above where we went into almost the 300s for his heart rate. Next slide. Again, this is just kind of the zoomed out view of over 12 hours with the heart rate where you can see he was in it for 3 to 4 hours before we could actually break him out of the SVT. And in this view, I actually had pulled in some of the medications below as well, and we'll zoom in on them a little bit more. But we had tried giving him adenosine to break him out of it a couple of times, which didn't work. You could see his heart rate stayed in the 300s. Go to the next slide, please, Karen. I think the next one, the animation will pop up. Here's a zoomed in version of where I was trying to look at some of his different meds. So as the attending who was taking over for him, I knew he was on the chronic medication of theophylline, which one of its side effects actually can be causing SVT. And so I had been given a report that he was on a subtherapeutic level of theophylline. So he got an extra dose and then his dose has gotten weight adjusted up to a higher level. So actually using sickbay, I pulled in all the different theophylline doses because I wanted to see how close were his doses back to back to back and how much was he actually getting. And could have that contributed to him actually going into SVT, getting all of those doses of theophylline? So you can see here those little purple marks as kind of the doses of theophylline. The one at the bottom, he got that mini load and then went up to the higher doses. So he definitely within 24 hours did get multiple doses of that medication. Next, Karen, one more. The animation will pop up. There we go. So then the other thing, so this is a similar view where I had theophylline. I also pulled in azithromycin, which is another anti-inflammatory chronic lung medication that we were using that can also cause SVT. And that one is higher dose at the 13 mg per kg. So that's the purple mark that's higher up. Just seeing the timing of that too, and could have that contributed to his SVT. Next slide. And here we actually get drug levels of theophylline. So when I was looking at all of the drugs, you could see first he was around 8. So he was subtherapeutic in his theophylline. That green zone is where we actually wanted his drug level to be. And even after getting all of those extra doses of theophylline, when he was in SVT, we had drawn a repeat drug level to see, oh, did we get him toxic with theophylline? Is that part of the reason he went into SVT, since he'd never had that history before? And even at that time, the theophylline level only went up to about 10, which is just barely into that therapeutic zone. So we didn't have any evidence that theophylline was necessarily toxic, causing SVT, but it was really useful to visualize the timing of all of these meds with his episodes of SVT. Next slide. Here is when I wanted to drill down a little bit more into the waveform data. So this is where I zoomed in into 12 seconds. So this was just looking at the different doses of adenosine and seeing if it broke the rhythm or changed it at all. And you can see here that adenosine really did nothing to this abnormal rhythm like we wanted it to actually break it. Next slide. Same thing again, I zoomed out more to see if maybe adenosine would break it a little bit later, but no real change in morphology. Clinically, I think this patient, they were worried that maybe the PIV wasn't working. Oh, you can go forward, Karen. But overall, the adenosine didn't do much for him. So here you can see there's adenosine, and then we eventually started an esmolol drip, which is those purple circles that are kind of longer. And we had to go up on the esmolol drip as another way of trying to break him out of this SVT. Luckily, his blood pressure remained stable this whole time, so it wasn't an emergency that we had to switch to cardioversion or anything like that. But eventually on the esmolol drip, he was able to break out of SVT, but you can see it took us quite a few tries and a number of different medications to convert him back to his normal sinus rhythm. And this is just a view that I put in there because I was looking through this all in sick bay, but this is one of our cardiac hemodynamic views we had available to us at Epic, because we use Epic. And you can see that I definitely could get some of that information that I was showing through sick bay, but down at the bottom, the cardiac medications that automatically pulled in were just adenosine and esmolol. And in this Epic view, I didn't have the ability to drag and drop theophylline or the lab values of theophylline that I wanted to look at with the timeline view in Epic that I could do in sickbay. So that's where I thought sickbay was a little bit more powerful to investigate maybe what actually caused this SVT in this patient. Right. And
Great,
yeah,
thank you for that, Dr. Knake. So you leveraged the meds view and kind of layering those on top of the hemodynamics data really heavily in this case. And I found it really interesting how you were kind of able to dive into, did this medication have the effect we wanted it to, or could this medication be having an effect we're not wanting? Can you talk a little more about how you process and kind of layer those two together, and how you can dive in a bit more to that patient specifically, or if that's useful versus just seeing the patient and trying to gather that same type of information or intuition?
Well, since I was the attending coming on the next morning and all of this had occurred, overnight, it was really helpful to go back and see what happened, what did they try and when. And it was nice in the sickbay view to be able to pull in the different meds that I wanted to look and really drill in versus, in Epic, I had a little bit more of a static view, which wasn't quite as dynamic. As the attending the next morning, I was wondering, should we just get rid of theophylline and stop it? Because I'm worried that this could cause this to happen again, which is why I really focused on that medication and ultimately ended up deciding to stop that medication. Although I didn't have super strong evidence that it caused this episode of SVT, I felt like it wasn't necessarily worth the risk, and the patient was stable enough without it that we decided to stop that medication.
Right, that's great. Thank you. So switching gears, let's take a look at a respiratory case for a patient with a history of pneumothorax. What were you looking at with this patient?
Yeah, so this is moving away from hemodynamics and more into what we can do with some of the vent data that we can get out of sick bay. So this was a patient who came to us who was a term baby who had a history of pneumothorax at the outside hospital that got decompressed with a needle once and then was transferred to us because they kept reaccumulating. Once the patient got to us, was intubated, given surfactant, and ultimately did require a chest tube to be placed to get rid of that large pneumothorax, and then was started on the antibiotics for pneumonia. You can go to the next slide. And this was at 2 a.m. Of course, all these patients always get admitted in the middle of the night when baby got his chest tube and was a little bit more stable from that standpoint. So you can go next. And then this is what happened at the routine morning x-ray. So after, the night team had placed the chest tube and thought he was stabilized at 2 a.m., it kind of wasn't until the 8 a.m. routine chest x-ray that they realized something went wrong and the chest tube had stopped working and the pneumothorax reaccumulated. So that black air, for people who aren't clinicians, is a large pneumothorax and is really squishing the lungs and the heart. So what I wanted to do is review in sick bay, why didn't we know about this sooner, or what were people missing, that it took this routine morning chest x-ray to realize that this patient had significantly changed. The next slide. So I put in just the post on the left is the post chest tube placement. So this is, remember the chest tube got placed around 2 a.m. So at the top is the peak airway pressure. So that's like the pips that we are getting out of the ventilator. And then in the middle green is the heart rate. You can see after 2 a.m., after they placed the chest tube, the baby also got put on some morphine, but the heart rate came down. The patient was calm, probably breathing more comfortably. And the saturations were stable and was only on the lowest one is a little bit of FiO2, only on 40% FiO2 at that time. However, I then wanted to look at the time prior to that, 8 a.m. routine morning chest x-ray and see what changed that maybe our team might have missed. And so you can see I think the middle line most dramatically is the heart rate. You can see our heart rate was stable up until like 8 a.m. All of a sudden it started climbing. And then above the heart rate, the pips, the peak airway pressure also really started climbing to pips of almost 70, which if anybody knows neonates, that's way too high of pips. So I do think that it was probably a pretty acute process right around that 8:30, 9 a.m. chest x-ray that all of a sudden things really changed. So it's not that our team had probably missed this for hours. I think that all of a sudden something happened that pneumothorax reaccumulated. And the FiO2 at the bottom actually was slowly creeping up and eventually got up to 100% FiO2 at that time as well. So there were probably some signs that people should have realized, but I think the worst part of it happened right before that chest x-ray. Next slide. So the other thing I wanted to look at is how, thinking of a systems and safety process for our NICU, is how do we end up getting PIPs so high? So the top line is actually the peak pressure alarm. It's kind of cut off, but you can see that initially that alarm was set at 45 for the PIP, and then somebody increased it to 60, to 70, and then to 80. And the reason being, the middle line is the tidal volume in the ventilator. So the tidal volume stayed the same, but the patient's lung compliance wasn't very good. So the ventilator kept alarming, not reaching tidal volumes, not reaching pressures. And so then whoever was on that night kept going up on the alarm limits to try to stop the vent from alarming. And you can see the very bottom is the PIPs, or the peak airway pressures, go up as you allow the limits increase to go up. So while they're just trying to get the vent to stop alarming, it actually wasn't very safe in this patient, because in a patient with a pneumothorax, you definitely don't want to use that high of pressure. It could cause what we saw with that pneumothorax becoming big and reaccumulating again. So this is where we really needed to do some re-education in our units of how to appropriately use volume control ventilation. It was PRVC mode, and be able to not increase those PIPs that high. Next slide. And this is just the view. Again, I looked at the view in Epic where you just don't have as granular the data of what the PIPs they were documenting. So here they only documented PIPs up to 40, which on the previous slides I show, we knew that we got higher PIPs almost to the 60s, 70s that I could see in sick bay. So I knew it was more of a problem than only the PIPs of 40 that people were documenting if you had just looked at the Epic documentation. Next slide.
Right. I think perfect. So
Yep.
then we're on to case 3, but for that case, can you talk a little more about some insight into using the alarm limit data and alarm data on top of, again, all of that waveform and vital data?
Yeah, so I mean, a part of what we do in medicine is we have to decide how and when we want to set our alarms to know when to notify people. And while we know like alarm fatigue is a huge thing going on in medicine right now, I think people were trying to prevent alarm fatigue from the alarms going off all the time. Let's just keep going up and up on the limits. But in reality, it was alarming for a reason, and there was an issue and some pathology in our patients. So we need to re-educate, some of our staff members that just going up on the alarms is not appropriate. You actually do need to notify the clinicians because something might be wrong. And we have to think through why are these alarms inappropriate. So although we don't think of alarms necessarily in medicine as important because a lot of times it's protocolized, but if people are increasing the alarm limits without letting you know, it can have significant consequences. And so this is a way for us to review that retrospectively in sick bay and then go back and do the education we needed in our unit to tell people how we should handle this in the future.
Absolutely. All right, so moving on to our last case, can you review the bronchopulmonary dysplasia or BPD case and tell us why you chose to talk about it?
So this is another patient with chronic lung disease, which will go a little bit back into some of those alarm limits that I focus on a lot with these patients. So this was a patient who was transferred to us because it had very severe lung disease, and they were hoping that we would, help with the ventilator management and find the settings that would work best for our patient. And she was luckily stabilized, but did need, some muscle paralysis and a lot of work to stabilize her and recapture her from an oxygenation and ventilation point of view. And then we were slowly trying to wean her off the sedation. Go to the next slide. You can see here, this is where I actually, after I found out about how alarm limits can go bad for certain patients, I started on my very difficult patients overlaying the alarm limits and the PIPs, the pressures, the peak inspiratory pressures that patients are hitting. So that top line is that alarm limit was set at 40. And so I could see here that every time those PIPs were getting up to 40 and hitting that alarm limit, the ventilator would probably be going off. But this was me trying to help my team think of, alarm fatigue and making sure it's not going off constantly. But in older patients, they might be wiggling, they might be coughing, they might be fighting the ventilator. So those are all legitimate reasons it can go off intermittently, and that's okay with alarm fatigue, but we don't want it going off constantly because then that's where we really get into issues. So this image is an image that I was okay with. It was just intermittently hitting that limit that we had set. But you can see that her PIPs were normally around 28 when she was calm and kind of as her baseline setting. So next slide, please. So this is just a picture of her x-rays. So for anybody who knows x-rays, this is a very bad chronic lung disease. And I was worried at this point we had recaptured her, but she was very hyper expanded and it was going to cause issues with squeezing her heart. So we had actually tried to come down on her PEEP on the ventilator, so decrease some of the end expiratory pressure we were giving her, which is the PEEP, to try to allow her heart to have better function and squeeze a little bit better. Next slide. So I had actually gone down on that PEEP. And so now the bottom line I have in sick bay is the PEEP. And when I went down on that PEEP to 9, you can see at the top line that my peak pressures at that 9:30 hour all of a sudden started hitting that 40, that alarm limit level, basically continuously. And that's when the bedside nurse came to us and said, hey, look, my ventilator is alarming continuously, something's wrong, which is what we want them to do. Instead of, just going up those alarm limits, right? We re-educated everybody, come to us and let's troubleshoot and think of what changed and why is this patient alarming continuously. So I had remembered that a couple of days ago, we thought the x-ray looked hyper expanded. So we had tried to drop the PEEP, but maybe the patient's airways actually needed that increased PEEP to keep certain airways open, because in chronic lung disease, airways can get really floppy really easily. So we then went back up on the PEEP from 9 to 10, and you can see over the course of the next hour or so, the patient was no longer hitting the alarm limits continuously. So this was a good way to confirm my hypothesis of, oh, my patient is peak pressuring all the time, because we had tried to change the settings and decrease the PEEP and she didn't tolerate it. So let's go back up, and we can now get her back to her baseline of, having more reasonable PIPs in the 30s and not always alarming the ventilator and causing our bedside staff to, get alert fatigue from hearing that alarm all the time. Next slide. So this is where I took screenshots from sickbay. So this is just the one time frame in sickbay where you can see she's intermittently hitting those alarm limits. Next slide. I wanted to compare this to other views I could use. So forward, here we go. So here's the same time frame in Epic, and in Epic you don't have the opportunity to put in the alarm limits there. You can see that in the middle one, the vent pressures, at some of that red line, the vent pressures would go up to 40 or higher, but it's hard for me to tell how frequently she's really hitting that limit and how much alert fatigue it would be causing to our bedside staff. Next slide. Here we have some unverified device data that we can view in Epic, and it gives me a few more data points, but still nowhere near the amount of continuous vent data we have through sick-based capabilities. Next slide. And then here's what is available on our servo ventilators. And the yellow lines are the peak pressure lines, and you can see them kind of going up and down in the peaks and valleys that we'd seen that this patient had done. But like the numbers are harder to see. You really have to scroll over it to get the actual numbers, but it does give you a little bit of a trend view. And then if you go to the next slide, the only way you can really see the alarms on the actual ventilator is you can hit the alarm logs and then see all the times that this patient is actually alarming, which you can get the sense that it is fairly frequently. But I felt that the sickbay visualization was better for me to know, like, oh, is it just every once in a while during cares or when she's agitated, or is it really continuously for 30 minutes and we really need to make a change? Next slide. So this is where I just left it, that I still preferred this. Out of all of those different views that I kind of looked at, I still preferred this sickbay view to look at that and get that clinical piece of information I needed to know how sick my patient's lungs were and if we really need to make changes. Next slide.
Yeah, and on this past slide, it's really interesting that you also demonstrated the difference between sickbay and what was displayed at the bedside on the device itself. In your experience, what would you say are the main differences between using sickbay versus devices directly at the bedside?
Yeah, no, great question. So I think there's pros and cons to a lot of different devices at the bedside. And while, you can always get more information watching the patient and seeing what the patient's doing on the bedside, in reality, I might have 15 to 20 other patients I have to go see. So I can't get that hours of information by looking at the devices and at the bedside or different things on Epic that don't have quite the granularity that I could see in sickbay, where I could go in a 3-hour view, a 12-hour view, and kind of get what was the story of what happened 24 hours before, and how worried do I need to be that we do need to make some vent changes today, and or see if my patient's getting more sick and is it quite as stable as they were the day before. So I felt like sickbay gave me a better way to look back at the times when I can't be at the bedside and look at those other devices and get a little bit more holistic view and really overlay the alarms and the pressure limits that I felt like I needed to see to make the decisions I needed to clinically.
Yeah, that's great to hear how you've used the customization and really getting to what is the most important for each case that comes up. We've also had a number of presentations with Dr. Rios about how you're also leveraging full resolution data for neonatal hemodynamics research. What are some of the research projects you are currently working on?
Yeah, I think Karen's getting back to the other slide. So I can't really do all of this justice since these are, Dr. Rios definitely knows more the ins and outs of these projects. But at the University of Iowa, we do have a very strong hemodynamics research team that does targeted neonatal echoes. So they want to compare some of the continuous data based on our art lines or our blood pressures or our heart rates to kind of what they're also seeing in their echo screenings as well. So we're, creating predictive models for fluid responsiveness or patients who might need blood transfusions, and are we seeing changes in their, pulse pressure variations or some of their hemodynamic things, depending on if they were getting dry or they needed a blood transfusion. And also trying to see what kind of down the line, what kind of cerebral autoregulation or cardiac autoregulation our patients are doing on their own. So we know better based on the gestational age and the weight of the patient, how worried we need to be about different patients if they need blood products or not. So a lot of exciting research coming down the line to really try to understand more about what we're giving to the patients and how their hemodynamics are responding.
Very exciting stuff. All right, so we have a number of questions from the audience in the chat. As a reminder, if you would like to add yours, the instructions on how to do so are shown on the next slide. Here we go. So our first question is, are you looking at using the data for other use cases such as virtual nursing?
Yeah, great question. So the way we have it in our institution right now is that we installed sickbay more on a research kind of instance, and it's just way our healthcare system works is that research funds are going for the implementation and maintaining of sickbay, since we have a number of research projects and grants supporting this. So those of us who are doing research in this area have access to sickbay and do use it for more retrospective of clinical scenarios, like I just showed in these cases, where I'll come back and go look back on the data I need, I think, to make clinical decisions. But unfortunately, right now, since we don't have all the clinical funds, just the way our health system works, to expand sickbay to get training for all the nurses and pay for it really on the clinical side, we are not using it right now for virtual nursing, but it's something we're actively trying to explore, since those of us who have access are already using it clinically. How can we open this to everyone, nursing, other physicians, maybe respiratory therapists, to be able to use this and monitor their patients, maybe when they're not standing right there at the bedside as well, using sickbay.
Great. And our next question is, you mentioned retraining and education about alarms. We have a lot of newer nurses on the floor. Can you describe the process you went through for that training?
Yeah, no, great question. So in the scenario I showed with the patient who had the pneumothorax, and we kept going up and up and up on the alarm limits there, part of why I put this presentation together was just to do some education to them about, why this can be dangerous and why you might not want to do that without notifying somebody. Then the other safeguard we did is we actually built an order into Epic saying that the clinicians should set the alarm limits for the ventilators. So there's one that's auto-populated, kind of our standard alarm limits. But if we want to go above and beyond that, you actually do have to, it's kind of that extra layer of safety guard, communicate with the clinician to change that order. So the new nurse, RT, whoever maybe who didn't get the education will know, like, oh, I can't just go up on these alarm limits myself. I have to communicate with the practitioner and make sure they're okay. Or maybe they want to come assess and reevaluate if something has changed in the patient before changing the alarm limits.
Great. Thank you so much, Dr. Knake. Unfortunately, we're at the end of our time today already, but thank you for joining us and sharing all this great information. It's always a pleasure. And thanks to our audience for participating. A replay of this webinar will be available at healthcaredatamatters.com. While on the site, you can also check out our previous webinars and join the conversation on our associated social media channels. As we close the meeting, you'll see a survey about this session. We would really appreciate you staying for one more minute to complete it, as it will help inform the content for upcoming sessions for the group. Thanks again for joining today. Here at Healthcare Data Matters, we are grateful to have the opportunity to advance a new standard of patient-centered, data-driven care. Take care, everyone.
Thanks, Jamie.
Thanks, Dr. Knake.